Okay, so congratulations, you made it through osteomyelitis and amputations, and now we're going to talk about osteoporosis and the other metabolic bone disorders. Osteoporosis is really the main focus of the metabolic bone disorders we're going to talk a little bit about osteomalacia and Pagets disease of the bone, and probably touch on bone tumors. But you'll get more content on bone tumors when you get into oncology, so I'm not going to get too in depth with that. And to be honest, the content that I'm testing on for exam 3 and the final for the metabolic bone disorders is really focused on osteoporosis. So for those of you that are test obsessed, not that it's not good to know about Paget's disease or osteomalacia, it won't hurt you, and you may encounter it in the clinical setting or see it on an NCLEX exam. But for exam 3 and the final, really, I want you to know a lot about osteoporosis, or at least as much as I'm going to give you. Okay, so we'll get started. Osteoporosis is not a normal consequence of aging. It is common in aging. It is more common in women than men, but it does happen to men as well. We've kind of already talked about this. Peak bone mass is somewhere between 18 and 30, but for most intents and purposes, what you have at 30 is probably what your peak bone mass is going to be. After which, we see a progressive and gradual decline in men and women, and then it gets more abrupt when women hit menopause, whether it's a surgically induced menopause when their ovaries are removed, or whether it is a natural menopause. But the loss of estrogen also increases the rate of bone resorption without replacement. So you think of your bones as the retirement account, okay? And you put bone into that retirement account until you're about 30, and then you start taking withdrawals. And for the most part, you're really frugal until you hit a certain point in your life, and then maybe you have to take more out of that bone bank. So the key to preventing osteoporosis, we said it was not inevitable. There are two things that you want to do, and you want to build bone while you can. And for this, we want to target teenage girls, young adult women, people who are still building bone. And the things that are associated with healthy bone, we talked about some of them when we talked about fractures and fracture healing, but dietary intake of calcium and vitamin D, and this is pretty important. So when you're learning, I'm going to give you guys a teaching assignment along with this presentation. It does not take long. You have to study anyway, but it helps you kind of focus what you're doing and give you a little bit of practice dealing with primary prevention of healthcare problems. Start to learn what the good sources of calcium are and how you can help people get more vitamin D, either through sunshine or through their diet. And calcium we've mentioned before, and it's just something that bears repeating because, you know, I want you to know this and have this information accessible to you. Dietary sources of calcium, we always talk about your dairy products. Yogurt, milk, cheese. Ice cream is not a real significant source of calcium, no matter what people tell you. Sorry. Cottage cheese, less calcium. You also see fortified orange juice. There are some products that have calcium in them added. Plant milks, soy milk, almond milk, and then your leafy green vegetables. So collard greens, broccoli, spinach, and then some of the cruciferous vegetables, the broccoli, the Brussels sprouts, have pretty significant amounts of vitamin D, or not vitamin D, calcium, excuse me. They have good amounts of calcium. Even comparable to milk when you go cup for cup. The difference is that it's very hard to convince people in the United States to, if 200 milligrams of calcium is in a cup of broccoli, how many cups of broccoli can you convince that person to eat? There is evidence that suggests that intake from food sources is much better absorbed than intake from supplemental sources. So really, when people are building bone, you want to encourage them. Those of you who are young women under 30 or who have teenagers, really talk to them about building their bone banks. They probably won't listen to you, but tell them anyway. Vitamin D. Vitamin D is not found in a whole lot of foods. You do find it in like the fish oils. It's in a lot of fortified foods like milk. You don't typically see it in cheese or yogurt, but it is usually added to milk. And vitamin D is made on our in our bodies on exposure to sunlight. Excuse me, I'm sorry, my throat's all froggy. But there's like a cholesterol-like substance under the skin that converts that sunlight into a form of vitamin D, which is then metabolized in the kidney into an active form that can be used. And vitamin D's role in this whole bank deposit thing is to take the calcium from the intestinal tract and put it into the bones, help escort it into the bones. Vitamin D and magnesium have similar roles in that. So think of vitamin D like your armored truck. You know, the calcium is the money you want to put in the bank, and the armored truck gets it to the bank, and then it, stays there until you need it. If you don't have vitamin D, the money sits, the calcium will be in your intestinal tract. It'll be excreted. It won't be absorbed. So that's something that you're going to tell younger women to do. Another thing that you want to talk about is weight-bearing exercise. Now, weight-bearing exercise is different from weight training exercises, which are also helpful because muscle strength helps build better bone. But weight-bearing exercise is exercise, obviously, where you have to carry your body around. So walking counts, running counts, even low-impact aerobics, as long as you are upright and putting some weight on your extremities. There's been a lot of people who work out might know about plyometrics, which is more of a jumping, a burst of energy, and then you sort of land on your feet, and you put a little shock on the bones. That can be appropriate for younger people. For older people, maybe not so much because of the stress to the joints, but walking is always advisable. Things like swimming, ellipticals, bicycling, things like that where you're not putting stress on the bones, do not build bone. So while they may be good exercise for the heart and the lungs and for losing weight and for muscle tone, typically they don't do anything for your bone bank. So weight-bearing exercise. We want to talk to them about avoiding certain things like smoking, cigarettes. Decrease the availability of calcium, and they cause decreased bone formation and increased bone absorption, as does excessive alcohol. Alcohol intake is also associated with bone loss or failure to build bone. Excess caffeine. Caffeine acts like a diuretic, and it'll cause excretion of calcium through the urine. So you want to avoid excessive caffeine intake. Normal caffeine intake should not affect it significantly. We'll say carbonated beverages, because that's what most people will understand. Carbonated beverages are full of phosphates, and if you know about the relationship between phosphorus and calcium, you know that that is an inverse relationship. And too much phosphorus in the diet. A little phosphorus is good for bones, but too much actually can interfere with bone remodeling because there won't be available calcium. Okay, so these are some of the things that you want to talk to people about while they're still young and building bone. Now, there are some other risk factors that maybe we can't modify. And we'll talk about those. Smaller stature. People who are shorter and thinner have smaller bones. They have less. They have smaller bank accounts. They have smaller bones. You can't rob as much from them. Gender. although osteoporosis strikes men as frequently, or strikes men as well as women. Men have a more gradual decline in testosterone. Testosterone has protective effect on the bones, similar to estrogen. So although men suffer from it, they usually get it later in life. Women who pass through menopause or have that surgical menopause are more likely to have osteoporosis. So gender, and then we just said postmenopausal status, or anything that interferes with testosterone in men or estrogen in women. Disease states. Remember the role of the kidney in vitamin D production. Think about the thyroid, the parathyroid. Think about adrenal disorders like Cushing's disease. Those things all impact bone density negatively. Hyperparathyroidism is one of the ones that causes extensive bone resorption without bone formation. So those are some of the conditions that can impact bone loss. Now, medications. In particular, let me change colors to keep you guessing. Corticosteroids have a very negative impact on bone density. So people who have asthma and have been using corticosteroids, lupus, arthritis, it's very important to get a very thorough history from people, because one thing impacts another, sometimes in ways that patients don't anticipate, but we as nurses certainly can. So your patient who says, oh yeah, I've had lupus for 8 years. Oh, what are you taking? And then they say methylprednisolone, let's say. And you go, wow, okay, so you're on steroids and you have a Colles fracture. You can start to put those pieces together. Anticonvulsants. In particular, we're looking at dilantin and phenobarb. Let me make that a little bit smaller. Hold on one second, just give me a sec. Appreciate your patience. Oh my goodness, dilantin or phenytoin and phenobarbital, which is just phenobarbital. Phenobarb affects the absorption and metabolism of calcium. And under disease states, I know we said things like renal failure and thyroid disorders and parathyroid disorders. But we're also looking at any conditions that cause a long-term lack of weight bearing, such as paralysis, people with spinal cord injury. So those are some things that you're looking at. And the less mobile people are, the more likely they are to have osteoporosis. And let me just shrink all this and put it in the corner in case you need to take a note or two. Those are some other risk factors. Okay, so what are the signs and symptoms? Let me see, yeah, okay. Signs and symptoms of osteoporosis. Well, sadly speaking, there aren't many until you get to fracture. The common fractures are going to be, the common fractures you're going to see are Colles fractures of the wrist, you're going to see vertebral fractures. Now here's the thing, remember in physical assessment we talked about the discs, the intervertebral discs getting thinner and losing fluid, so you have less cushion. Now you have brittle bones. And if that person has to absorb any kind of impact, and sometimes it could be the most ordinary activities, you go over a bump in your car, think about the impact. You might see little stress fractures in the vertebrae, usually in the thoracic spine. That is where you commonly see them, because we also see kyphosis. And so those bones aren't giving each other the support. They're not stacked on each other in such a way that they're going to give each other support. So you have bones that, are maybe in a more precarious position. You have less shock absorber in the vertebral discs, and then you have a brittle bone structure that impact is going to, you know, have a more serious consequence for that person. So back pain can be a sign. Sometimes people have little vertebral fractures and never even know it. Okay, so what are some other things that we see with osteoporosis? We're going to see a reduction in height. And my friend Leslie was just diagnosed with osteoporosis. She worked in the nursery with me for years. She still works there. I just don't. And she was only about 4'11" to begin with, which is one of the risk factors that we talked about, that shorter stature. And she said, at 4'11", everything sort of counts. And she noticed that she was getting shorter. And she noticed it most especially. Her daughter got married, and she was in the pictures, and she realized how much taller everyone else was around her. And when she went for her Dexa scan, because she's a good girl and she follows her doctor's advice, they did identify that she had osteoporosis. And so that reduction of height can sometimes be your clue. Let me open that up a little bit. How about kyphosis? Let's talk about kyphosis. We've seen it in the Jarvis, in your Jarvis text, that dowager's hump. It's an exaggerated curvature of the thoracic spine. I also talked about it in assessment of the musculoskeletal system. But kyphosis is common. It is an indicator of bone loss, or can be an indicator of bone loss. So when you're seeing somebody with that reduction of height and kyphosis, and again, you know, we talked about some reduction of height from the intervertebral discs, but if you see a pretty significant reduction of height, like 2 inches over a year or two, you might want to refer that patient for some further testing. Back pain, and this is related to those little stress fractures. It's usually after lifting or bending, relieved with rest. You might see a restriction in movement, you know, a little bit of stiffness. That might be more related to the joint support. Under fractures, I had forgotten to mention, I'm just going to add it now. Fractures of femur can sometimes be somebody's first clue, and that's unfortunate. The femur is the largest, strongest bone in the whole body, so when it breaks, it's a pretty big signal. Either that force was significant, or you've got really poor bone density. So people who have fractures of the femoral head, or fractures of the pelvis, but usually you'll see it in that greater trochanter, the intertrochanteric fractures. Those are big tip-offs. And hopefully this isn't the way that people have to be diagnosed, because we have better tools. We have the Dexa Scan. We have other bone densitometry scans. I'll say that 5 times fast. But bone... the reason that we talk about Dexa, it's the most common one that you're going to see ordered for people. There are other scans. But Dexa is a very easy way to scan bones, and it tends to be very predictive of fracture risk. And we talked about those T-scores. That's how our Dexa scans are reported. Excuse me, I'm sorry. I'm getting a Facebook notification at the same time. Okay, our T-scores. And just to review, you had this content, you showed me you know it, but we're going to say it again because it just helps the learning process. A T-score they're measured in standard deviations from normal, healthy, young adult bone, but from 0 to negative 1.0 is normal. There it went. Okay. Sorry. Okay, if you have a T-score that is negative 1.02, do that so it's less confusing, negative 2.5, that's osteopenia. This person is probably not likely to have a fracture without significant trauma. I mean, anyone can have a fracture. Healthy young people have fractures, but it takes more force to break that bone. This person is less likely to develop a fracture than somebody with osteoporosis, but this is a progressive disorder, so maybe we want to intervene here to decrease the risk of progression to osteoporosis. and to decrease the risk of fracture and all the complications that come from it. Now, if you have a T-score negative 2.5 or greater, this is osteoporosis. Now, there are women walking around, and probably men too, who have osteoporosis, and they don't feel sick, and they're not breaking bones, and they do fairly well. But osteoporosis can progress, and so we want to really slow down that progression of bone loss. Sorry, let me just put that up there. And get some good lifestyle changes in there, medication if necessary, and try to get that person to prevent fractures. We're also going to look at things like falls risk. If that person has other risk for falling, we're definitely going to try and get OT and PT involved to help them improve their balance. We're going to reduce the clutter in their room. We're going to reduce anything that could get them to fall. We're going to do that get up and go test, if you guys remember it, from Basic Needs. These are people that we really want to watch and make sure that their risk for falling and their risk for injuries due to impact are reduced. We're going to have them modify their activity. We want them to get activity. We still want that weight-bearing exercise and that strength training. But what we don't want is we don't want risky activities like mountain bike racing or horseback riding. You'd be surprised. People do all kinds of stuff. People who love horses that could get thrown off of them. We want to stop that. Running for people who aren't used to it. If you have osteoporosis and you do that, the risk of stress fractures is greater. And that's all your risk for injury. So those are your T-scores. While we're talking about bone densitometry, let's just say Dexa Scan, even though that's only one type. How do we prepare our patient for Dexa Scan? Well, first we teach them, what is a Dexa Scan for? We'll screen you for osteoporosis. And if you already have osteoporosis, or even if you don't, it predicts fracture risk. It is one of the components of the World Health Organization's FRAX Tool. And we'll kind of talk about that in a minute. But usually we do a Dexa scan in the hip or the spine. We might do a heel. We might do 2 sites. A Dexa uses 2 beams of radiation, and then the computer analyzes them, and a radiologist reads the scan, and then they get their T-scores. So your instruction to the patient, Dexa scan is painless. It's not invasive. They're going to have to lie still on an x-ray table. They should remove jewelry. The whole thing takes about 15 minutes. And that's really the education. Most of the education you're going to give your patient is about osteoporosis and how to decrease their risk and what to do with their T-score information. So current recommendations are that all women older than 65 years of age have a baseline Dexa scan, and that all women older than 50 who have gone through menopause get a Dexa scan. Although some doctors, based on their knowledge of the patient and their preferences, may have a woman screened earlier, maybe prior to menopause, just to get a baseline reading. Now, whether insurance will pay for that or not, it's unclear, but anyone certainly with risk factors for osteoporosis should be screened, maybe on the earlier side rather than the later side. So one of the useful things about the Dexa scan is that the T-scores can be used as part of a FRAX tool. The FRAX tool was developed by the World Health Organization, and it is a fracture risk assessment tool. And they make treatment decisions based on the information that they get. And what they do is they take your T-score and combine it with history, personal or family history of fractures. They look at body mass index, gender, height, age, medication use, smoking, corticosteroid use. They do not use diabetes currently, although the evidence is emerging that patients with diabetes have a higher incidence of femoral fractures. So that is what the FRAX tool is. And your book goes into probably a whole paragraph about how those scores are used. Basically, they look at your fracture risk and decide whether or not to treat with medications, which is something we're going to talk about in the next slide. And then one last consideration, we talked about laboratory studies, and I just wanted to touch on that because people looked a little, I saw some frowns in the classroom that some folks were maybe a little concerned about keeping them straight. What you need to know is lab studies are not terribly reliable diagnostic testing for osteoporosis. However, you may see them ordered just as a differential because sometimes osteomalacia or Pagets disease, because they're also disorders of bone formation, resorption, remodeling. You might want to see what's going on. You might want to look at causative factors that you can address, like thyroid disorder, parathyroid disorder, but I would not get too crazy in worrying about your lab tests for that, for osteoporosis. Mostly what you're using are your imaging tools. Okay, so if you have a patient now who has been diagnosed with osteoporosis on the basis of T-scores, or whether there's been some sort of fracture, Colles fracture, a stress fracture, the first thing that you're going to want to do is institute the lifestyle modification that we talked about. It's very similar to what we talked about with our younger patients. We're trying to get them to build bone. Now we're trying to prevent further bone loss. We're going to try and slow the progression of this disorder. So again, we're talking about smoking cessation, calcium, making sure that their diet's adequate, has adequate calcium and vitamin D. We're going to have a talk about caffeine, alcohol, and we're going to need to get them on some weight-bearing activity. Now, if your patient already has osteoporosis, do not suggest running or plyometrics or anything like that. You do not want to increase their risk of stress fracture. You want something that is low impact but not no impact. So, I know they have the silver sneakers classes, but you don't necessarily have to push those. Sometimes patients have osteoporosis and they're on the younger side, and they might enjoy walking, they might enjoy other, lower impact activities, cardio kickboxing, or, there are people that do all kinds of stuff. It's just you want to really avoid the impact of like heavy landing. So that pounding, running type motion we want to avoid. Along with the weight-bearing exercise, we also want to do some strength training and maybe some exercise that helps improve balance and flexibility, because these things will all impact their falls risk. So the ideal exercise program for somebody with osteoporosis or at risk for osteoporosis would include weight-bearing exercise, some strength training, and maybe yoga for balance and flexibility, or other stretching exercises. But that would be your lifestyle modification. And also avoiding those carbonated beverages, any of those things. And if that patient is on corticosteroids, we might have a talk with the physician about tapering or looking at alternatives. Although if they have a disease that only responds to steroids, we're just going to have to take that into account. So when lifestyle modification is not enough, or if the fracture risk, according to the FRAX tool, is high, we might institute some pharmacological management. And your book includes dietary supplements along with this. My feeling is that people take dietary supplements, and it's not necessarily a medical thing, but particularly for patients who are at risk of not getting enough calcium, or patients who don't absorb calcium that well, we want to maybe look at doing some dietary supplements. And I don't know if you guys held on to that handout that I gave you. Nutrients nurses need to know. If you want another copy, let me know. I have it saved to my computer at work. But remember that calcium and iron cancel each other out, and then neither one is effective. So if you're giving a multivitamin with iron, space that calcium at least 2 hours afterwards. Another consideration, since we're mostly dealing with older adults with calcium supplements, adults that have decreased gastric acid production may not get as much calcium from supplements like Tums, which are from calcium carbonate and need an acid environment to work. They may need a different kind of supplement, and this is maybe where your medical team wants to advise. calcium citrate is a much more absorbable form of calcium. It's a little more expensive, and it's harder to find them in those little chewy things and stuff, but that might be an option for people. If you can get a vitamin D supplement that goes in the calcium, that's even better because they work well together. But that's your dietary supplement, and we're going to supplement anybody at risk for osteoporosis, or anybody who can't get enough calcium in their diet or can't absorb it that well. Okay, our next class of medications are the biphosphonates. Let's see if I can get that, pull that out from there. And yep, that's what I have to do. Okay, your biphosphonates. When we get to class on Tuesday, I really want you guys to bring a drug reference. I'd like to try and do, and if you can print off an ATI template, that would be ideal. If not, I'll bring some. But I'd like to do one template as an in-class activity on the biphosphonates, because this is a medication that is commonly prescribed to women, and even, or actually for both genders. Estrogen reuptake is females only, sorry guys, but your biphosphonates can work for both genders, but you'll see a lot of patients come in the hospital and they're on them. So probably the prototype for that is going to be Fosamax, and let's talk about that. So Fosamax is also known as alendronate, and the way that a biphosphonate works is that it decreases the number and action of osteoclasts. Osteoclasts, remember, were those cells that rob the bone bank to pay the serum. You know, they take the calcium out of the bone and put it into the serum. So it's biphosphonates decrease the osteoclasts, and they prevent and treat osteoporosis. They also work well for hypercalcemia, folks who get high calcium levels, and for Pagets disease of the bone. Other drugs in this class are, let me try and get that in there, ibandronate, also known as Boniva, and risodronate. So all these dronates, Actonel. But the one that, you know, for your template you're going to do is Fosamax, and then you can put those other names up there if you want to. Let's see if I can get that. Oh. There we go. Okay. So those are the biphosphonates. Now the big concerns with biphosphonates, that all the side effects and all the adverse effects are really GI based. You have, usually patients will complain of nausea, indigestion, gas, and then they may have diarrhea or constipation. But the big adverse effect that you want to watch for is, and let's change colors just to be fancy, and that way I think you remember it a little bit more. Adverse effect is esophagitis. And esophageal erosion or ulcers go with that. I'll just put that down and give you time to write your note too. There. Okay, so these are the big adverse effects. So how are we going to prevent that? Well, I need a little more space on the board here, so let me shrink some of my stuff and put it in the corner. I don't think you need this yet, or that, or that. So let's kind of look at that. What instructions are we giving to our patients when we give them this prescription for Fosamax? Number one, this medication only works when taken on an empty stomach. So 60 minutes before you eat or after. You have to really, it's the first thing when you get up in the morning. You cannot eat breakfast for 60 minutes after you take this medication. There you go. So remember that if you are taking Fosamax, get up in the morning, early in the morning, before you have eaten anything. Then the next thing that you're going to do, let me put that up there, give you another chance to write notes. Okay. The other thing is that they need to remain upright for 30 minutes after they take it. So this isn't one of those things where they can put it at their bedside, set the alarm, pop a pill, go back to bed, wake up in half an hour, and drink their coffee. By the way, it isn't just eating breakfast. It is drinking coffee, brushing teeth, having a sip of orange juice, or a sip, anything but that full glass of water. Oh, that's another thing I forgot to tell you. Here, let's shrink that. They must take it with a full 8-ounce glass of water. Not milk, not juice, not coffee, not tea, not wine spritzer. Must be a full 8-ounce glass of water. Okay? So there's your instructions to your patient. Then you're also going to teach them, where am I going to fit this now? Okay, how about over here, and then I'll erase some of this stuff and make room for other things. You're also going to teach them, report to their doctor if they have like acid reflux, sore throat, and that would be from the acid coming up, or burning in the esophagus. And certainly if they're having any chest pain, any bloody vomit, any difficulty swallowing, you would hope that they would call their provider, but tell them to do it anyway. Just so you know, this information here, all this yellow, let me move this so that it's all in one spot because I don't want you to get confused. Okay, so this is all about our biphosphonates here. So there we go. All right, so if they have those symptoms, if they have the acid indigestion, if they have the sore throat, if they have trouble swallowing, chest pain, burning in the esophagus, really bad heartburn, they need to talk to their doctor right away. Okay, if you've had some time with this information, I'm going to shrink it and sort of move it up into the corner. Here, let me just put that away. And we're going to talk a little bit about estrogen. Now, here's the thing. ATI still talks about estrogen replacement therapy or hormone replacement therapy as a way to prevent... I'm sorry, I'm going to overlap some of these just to get them out of the way. So if you had time to take notes, great. I can actually get rid of them altogether, but I might want them later. So we're going to talk about estrogen. This is ladies only again. Sorry, guys. But your ATI does talk about hormone supplements. It really is not considered a best practice, according to evidence-based practice, to give people actual estrogen or estrogen with a progestin component like Premarin or Prempro. Really, we used to give these for symptom relief, and then there was talk about bone health. But the cardiovascular risk factors from actual estrogen replacement therapy are very high. So if your main reason for doing it is bone health, they really are not encouraging that as a best practice. But we do have selective estrogen reuptake modulators, or SERMs for short. And the prototype for this drug, and it might be the only one that I see mentioned in any of your stuff, is Evista. And Evista is also known as raloxifene hydrochloride. Okay, and the way that Evista works is that it decreases the activity of osteoclasts again, and it decreases that bone resorption, and so then your bone density should be preserved. Now, it treats postmenopausal osteoporosis. It also treats breast cancer, interestingly enough, because a lot of breast cancers are estrogen sensitive or estrogen dependent. So, what are the main nursing considerations for this? Let's make some space here. Nursing considerations. Okay, they increase the risk for DVT. Whoops, sorry, not DVT. My goodness, what's wrong with me today? DVT, deep vein thrombosis. they sort of give you that hypercoagulable state. So this is something that your patient should know, and they should be aware that they need to report to their doctor immediately if they have calf pain, redness, heat or swelling, especially on one side. The other thing that we're going to want to do is monitor their liver function. This is a drug that is extensively metabolized in the liver. And your LFTs, I know you guys haven't had that content yet, that's next semester. But liver function tests include tests of bilirubin. You're going to look at AST, ALT, LDH. These are all liver enzymes. When the liver enzymes are elevated, they tell us that there's been some kind of liver damage. So you're going to monitor those. Instruct your client that they still need to take their calcium and vitamin D. Some people think you've given them a pill now, so they can go back to their crappy lifestyle. That is not true. This medication and all these medications work in conjunction with lifestyle interventions. So that is a Vista in a nutshell. And that might be a drug you see. Okay, so I got rid of some of the clutter. And now we're going to talk about Forteo. Forteo is also known as teriparatide, and I'll write that. It's easier to read than it is to pronounce. That's the generic name for it. And this is a parathyroid hormone. The parathyroid the gland makes some hormones that increase the, they either increase the activity of osteoblasts or osteoclasts. And Forteo is a synthetic version of one of the parathyroid hormones that increases the activity of osteoblasts. Okay, remember that means you're going to make more bone formation. It also increases the absorption of calcium from the GI. And so that is how Forteo works to help halt the loss of bone from a patient with osteoporosis. There are some nursing considerations, and that's always what we're interested in. It's only administered sub-Q. And because it's action on the absorption of calcium, we're not going to give it if your patient has hypercalcemia. Okay, so this is where it's helpful to know your signs and symptoms, because this is when you're going to teach your patient. I mean, it's possible that they could become hypercalcemic while they're on this medication. So we want them to report any leg cramps or bone pain to their provider. And we want them to go for regular lab work. A lot of these drugs that we give to people for chronic conditions, we want to monitor lab work. So that is Forteo, okay? And while we are on the subject of parathyroid hormones, there is another medication, and it'll be the last one we really talk about, calcitonin. You can get human calcitonin, or you can get salmon calcitonin. Okay, and the brand names for this are, make some space here, miacalcin and Fortical. And again, we talked about the role of the parathyroid hormone. This is a thyroid hormone that decreases bone resorption. It inhibits the osteoclasts. So where Forteo increased osteoblasts, calcitonin decreases, excuse me, I don't know, I have a speech disorder today, decreases osteoclastic activity. And so it not only treats osteoporosis, but it treats diseases that have abnormal bone remodeling as a component, such as Pagets disease of the bone or hypercalcemia. So this could be a treatment for that calcium imbalance. Nursing considerations, as always. Come on. Okay, so the human form of calcitonin can only be given sub-Q. Okay, the salmon can be given, let me make a little bit of space there. Okay, salmon can be given sub-Q, intramuscularly, so IM, or intranasally. And I'm not sure what the absorption rates are for intranasal calcitonin, or, salmon calcitonin. I'm really not familiar enough with it. But I think that for some patients that might be a preferable route. So that is calcitonin. And that really concludes the medical treatment. Everything else would be lifestyle modification and decreasing falls risk. And then, of course, fracture healing when you have that complication. Now, there was one additional class of medications that your textbook went into. I am not going to go into detail on them because I think we've had enough medications for now. But they're just so that you know what's on the horizon for folks. The rankle therapies are for people who just don't tolerate the other medications and they're very high risk for fractures. So you have Prolia, and these increase bone density by inhibiting tissue necrosis factor. It's like an antibody thing, and it's in one of the newer treatments. They do reduce vertebral and risk fractures. So it's something to keep in mind, but you're not going to be tested on it, and you might not really see too much of it. If you do, you'll probably have to look it up just like I would. So that concludes osteoporosis. You guys are done with this week's content. Have a happy Thanksgiving, or hope you had a happy Thanksgiving. You'll probably be watching this tomorrow or the next day. All right, good luck. Oh, sorry. I did forget to talk about the other metabolic bone disorders, and I did promise that I would. This won't take long, though. We're going to first talk about osteomalacia. And osteomalacia is sort of the grown-up version of rickets. They have the same cause, and that is from vitamin D deficiency. Okay, the difference between rickets and osteomalacia, very quickly and very simply. Rickets happens to kids before those epiphyseal plates close. Osteomalacia happens to adults after the closure of those plates. The symptoms are very similar, and let's get a picture of that up here. I just have the x-ray picture. There were other pictures, they were kind of tougher to use, but let me get that to a place where it's a little bit manageable. And what you're going to see, the clinical manifestations of osteomalacia are bowed legs. That's the big one. So bow-legged appearance. And then sometimes some kyphosis. You also see bone, or you will also get a patient history that states there is bone pain and there is evidence of muscle weakness. These folks are at risk for falls. If they do fall, they're at risk for fractures. The bone is soft. And there are multiple risk factors for osteomalacia. And one of them is poor dietary intake and lack of sunshine exposure. But also your liver and kidney disease. And remember that test question from Unit 3, or whatever it was. People with kidney disease cannot convert vitamin D into a form that can be used by the body. No vitamin D means you can't get the calcium. It's that armored truck that gets the calcium to the bone. And so now the bones that are, with an adult that have been formed are weaker and softer. Okay, so you get a bony fibrosis because what happens is that the body is constantly taking from the bone. They're constantly robbing the bank until there's almost nothing left. And then the parathyroid kind of kicks in as a compensatory mechanism. And there's just a cascade of things that happens. But risk factors, again, we were talking about poor dietary intake, lack of exposure to sunshine, and any condition that makes vitamin D less available to the body, including liver and kidney disease and gastrointestinal disorders where there's less absorption, especially decreased absorption of fats, because vitamin D is a fat-soluble vitamin. Okay, so how do we combat this? We, again, talk to people about calcium and vitamin D. I mean, that's just a running theme with a lot of these disorders, is that good diet does a lot to prevent this. Medical management, we're going to support the patient, of course, reduce their pain, but really most of our interventions, most of the medical interventions will be aimed at correcting the underlying cause. If you have kidney disease, you're going to have to supplement in a form that's already a form of vitamin D that's already actified, and that's calcitriol. You're not going to give them regular vitamin D. You have to give them the vitamin D that's already been activated, because the kidney will no longer do that for them. If you have malabsorption syndromes like celiac disease or patients with gastric bypass, other gastrointestinal disorders, you're going to give them higher doses of vitamin D supplement. Or you might have them go out in the sunlight. It's sort of one of those catch-22s. Is we tell people not to go in the sun because the risks of skin cancer are increasing, and malignant melanoma does kill people. But vitamin D is important. So maybe we want to have some limited exposure, 10 or 15 minutes a day, when the sun is out, to get that vitamin D to be activated in the body. Dietary, again, supplementation, and then as far as long-term care of patients who have experienced rickets or osteomalacia, we're going to prevent falls like we always would, and then in terms of correcting the deformities that come with this, you might have surgery, or there might be braces that are used to correct the appearance of the bones. Okay, so now we're going to talk a little bit about Pagets disease of the bone. Again, don't fixate on it. If it's something that you see on an NCLEX exam, don't panic. Here is what Pagets disease is in short. It's a disorder of bone remodeling. You have inappropriate bone remodeling. There's an increased production of the osteoclasts, and so you get bone resorption. Well, once the body senses that, the osteoblasts sort of kick in, but then there's a randomness to it. The bone is diseased, but there's a lot of blood flow. It's just the bone isn't formed correctly, so it's prone to pathologic fractures. Some bones get a little thicker. You might see lumps. The first symptom that most people will report is that their head gets thicker. Their hat doesn't fit anymore, or they feel like their head got bigger. So the face looks smaller, and the cranium is, enlarged. You might get some hearing impairment from cranial nerve compression. And sometimes other cranial nerves are affected. You might see bow-legged appearance with Pagets disease as well, and a waddling gait. You see a little bit of kyphosis. People have problems with balance and gait, and again, you might get pathologic fractures, and they're at increased risk for falling. Because of the increased vascularity, their bones can feel warm. Now, this is where your alkaline phosphatase kind of comes in. Remember, we said that with osteoporosis, the lab values were mostly for differential diagnosis. Well, in Pagets disease, we have increased alkaline phosphatase. And remember, we said alkaline phosphatase is increased when we have bone growth, when we have fractures that are healing, and when we have inappropriate bone formation, either with bone cancers or metastasis to the bone, or with these disorders like Pagets disease. You also see acid phosphatase elevations, which normally acid phosphatase is more related to prostate problems, but you will see that value increase as well. I'll just put it there. And I'll put a little comma over here. Just, oh my goodness, how did that happen? Somebody's in halo traction. That's terrible. Here, start over. Alkaline and acid phosphatase are increased. Okay. You might get, on a urine screen, you'll get this, some chemicals are altered. I don't really want you to obsess with that. Pagets disease is normally normal blood calcium levels, and you can confirm the diagnosis with x-ray, because you will see some areas it's patchy bone growth, and it's just inappropriate bone remodeling. Normally, I mean, it's amazing how many things in our bodies go right every day and we never give it a thought. Normally, bone's resorbed, new bone is formed, and there's this sort of seamless, a femur always looks like a femur. But with Pagets disease, you might get areas where the bone is very weak and very lacy and very porous, and other areas where the bone overgrows, and some deformities with that. And the bone scan, the thallium and gallium bone scans, tend to really show exactly where things have gone awry. So you can do a bone biopsy, but your book says that it's really just a differential again. So that's Pagets disease. And not to be confused, there is a Pagets disease of the breast too, but that's completely separate. And I want you to, like, if you're Googling this or looking on the internet, be aware that there are two diseases that have the name Paget. Pagets disease of the bone is the one that we are concerned with in musculoskeletal. It has nothing to do with breast cancer. Just be aware you might see that when you search for it, and don't get confused. Okay, so the complications of Pagets disease. Obviously, you see fractures, pathologic fractures. When you have these patchy areas of the bone where some bone is very porous and some bone is overgrown, you get pathologic fractures. You can have arthritis. Bones that are all screwy are going to put different stressors on the joints. It's not going to be the, that balanced weight that goes on that joint. They're going to be asked to bear weight in a way that they don't normally, and to move in a way that they don't normally move. Hearing loss, we already said, because with that thickening of the skull, you get compression on cranial nerve number 8. And you may end up with, complications, because if you try to do an internal fixation or an external fixation, or you try to do a joint replacement for these folks, the bone may be softer in the spots where you need to attach the hardware or go in and sort of fix things. Hearing loss, it's supportive care. You're going to maybe get that person fitted for a hearing aid, but that's really what you're going to do about the hearing loss. Once they lose that, that's, once the cranial nerve is involved, there's really not a lot you can do. Hearing aids and, communication, alternative methods of communication. Okay, so how do we treat Pagets disease of the bone medically? Let's get rid of that. And we're talking again about biphosphonates. Aren't those medications just amazing? And that, again, is your Fosamax. They stabilize all this rapid bone turnover, and they suppress the Paget symptoms. There is another medication that is used. It is called plicamycin, otherwise known as mithrasin, and it's an antibiotic for severely affected patients. It has effects on pain reduction and on serum calcium, but there are side effects. It's not really the most common treatment for Pagets disease. The reason that we use it, even though it's an antibiotic, it's cytotoxic. So it's sort of like a chemotherapy medication in a way, like methotrexate or one of those. We do not, as far as I know, use methotrexate for Pagets disease. I'm just saying it's cytotoxic. So it kills all these overgrown cells, but it kills other cells too. So plecomycin, I think, is really administered with caution. The biphosphonates, like Fosamax, are really the cornerstone of therapy, according to your book. This disease tends to affect older adults. So if they were already getting that presbycusis, that age-related hearing loss, this can sort of accelerate that. They're already at risk for falls and fractures. That can accelerate that. So it's all the same things that you would do for all of those problems, and really the education on the biphosphonates. Remember to take it first thing in the morning, 60 minutes before you take anything except that 1 8-ounce full glass of water, and then you remain upright for 30 minutes. So make sure that you're educating that patient about Fosamax. All right, and now you really, 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 I promise, are done. Happy Thanksgiving.